background is actually a very long time ago as a labor and delivery nurse and postpartum newborn and lactation consultant, actually, such as they were in the late 1970s. I then went back to school to become a genetic counselor and got a master's from University of Wisconsin. Best thing I ever did. And came here to become a genetic counselor. In the late 1990s, I went back to get my nurse practitioner and in pediatric nursing, but it's basically genetics. And I've worked there ever since. I have coordinated this Nebraska Teratogen Information Service for 35 years. In terms of doing it, we're one of the oldest ones in the country, and we do both pregnancy and breastfeeding questions. What things are reasonable to use in pregnant and breastfeeding women, and it is my passion. So I am thrilled to be here to talk to you. I should say I am a faculty member at University of Nebraska Medical Center.
Mark Woodruff.
Are we okay? Yes. And lucky to be so. It's something I enjoy tremendously. So glad to be here to speak to you. So we are talking about advanced concepts in breastfeeding women, and I am not the one anymore that knows about many of the questions women have about breastfeeding, but I sure know a lot about the questions that have to do with what's safe to take during breastfeeding, and I answer them every day on the phone, by chat, by text, by email, because our national service does that. I will tell you more about resources. We'll start a little bit now, but at the end, there's a whole section on resources, which might be the most important thing that I tell you. One of my favorite, I love Gary Larson, and one of my nurse practitioner friends gave me this one to wash hands. Anyway, okay. And there's our Nebraska TIS. If you want to get me directly, that's my 559-5071 comes into my desk. I'm often in clinic, so you just leave a message and I get back to you. In terms of doing it, we do lots of education, both through my faculty position and outreach, and we participate in international research on the impact of medications in pregnancy and breastfeeding. I just got back from an international meeting in Denmark regarding that. So I know many of you are aware of what I consider to be the two best resources, although let me say that part of my job is to know where else to look if I don't find it in Hale or Anderson. So there's Thomas Hale and Medications in Mother's Milk. And although that's a picture of the book, I'm sure most of us get his information online, and then it's up to date. He's now hired several pretty sharp young PhDs who also attend our Otis Mother to Baby journal club and things, and they're doing a lot of interesting research. And I think that the book and the online thing are just getting better in terms of doing it, which is lovely. And then this is Philip Anderson. I've known him also for a very long time. He's from San Diego, UC San Diego. And so let me say, you probably know there's a charge for the Hale Medications and Mother's Milk. The one that we purchase is $425. Phil Anderson doesn't charge anything for his information. It's at the National Library of Medicine, LactMed, and I'll talk to you more about that. Mother to Baby supports his app right now. But so I consider Anderson to be a little more academic and how he handles things and references it, and Hale to be a little more clinically kind of hands-on, useful in terms of doing that. But we use both all the time, and they're wonderful. Thank goodness. I practiced before we had either, and had to do a lot of scrambling to figure out involving the label or calling someone who might have some experience with a particular medication. So, okay, my first 20 slides are kind of to do with the theory back here, because this is an advanced class. And so kind of what we do to think things through and how we might go about minimizing exposure. Then we're going to go through and talk about some examples, depression in particular. We're going to speak about some over-the-counter herbal kinds of things, galactagogues in terms of doing it. Then we'll take a break and come back and go over vaccinations, substance abuse, over-the-counter drugs and cosmetic things, and then go through the resources of it that we were talking about. We'll do a couple case examples if we have time. I would be thrilled if you ask questions, so please do suggest you're following along in terms of doing that. Okay, so we all know breastfeeding is good for the mother and baby, but of course not if the baby gets something that's toxic or so sedating that it, doesn't nurse properly or whatever. So in my experience before I started doing this, running this service, was that it was kind of an all or nothing. A lot of the doctors would just say, well, breastfeeding is good, so take whatever, because the being good outweighs it. Or they'd say, well, there's not much data and can't be sure it's safe, so you shouldn't breastfeed. So it was, and of course, the truth is it's something in between, and we know that there are strategies we can do to lower the risk, different alternatives, things like that. So we'll talk about it. So fortunately, most things, even though I think that almost everything ends up in breast milk, unless it's a really big molecule, and there are some things out there like that, most of them end up in breast milk, but often in amounts that are 1%, 2%, 3%, 5% in terms of doing that. However, there are things that are really toxic or risky, that even a small amount, and particularly with a vulnerable baby that wouldn't metabolize it very well, are going to be a problem. One thing, just to remind you, you already know this, is that people that do it all the time, is that different agents may be preferred for pregnancy versus breastfeeding. This is really true of sedating agents, for example, that you could give many of them, at 6 months of pregnancy because you don't care. You worry about it at newborn, delivery, but you really don't want it during breastfeeding. Things that reduce milk supply, and then there are things that we can use in breastfeeding. I just talked to someone yesterday about using pain medications, and they were concerned about ibuprofen. Well, true, we do not use ibuprofen during pregnancy or other NSAIDs, but it's a very good analgesic, and very little in breast milk, and you can give it directly to the baby and has all of those things. And so both the provider and the patient were confused about the fact that no, you can't use it in pregnancy. Yes, now you're breastfeeding, you can use it. I've also had people use the old FDA codes, ABCDX, for breastfeeding, and no. They not only were they bad for pregnancy, they weren't very good for that, but they had nothing to do with breastfeeding. So don't do that either. You wouldn't do that. I know you wouldn't. Okay. So I think of everything, and I actually explain it to patients this way, and they kindly nod their heads as I tell them. But I think it's important that that it's all about risk and benefit. And you can tell I'm in genetics. This is how we think. But is there a big benefit? Well, if there's no other, even though the baby might get some, and there's no alternative, and then we might take a small risk and monitor the baby. We'll talk more about that. Is there no real benefit to the health of the mother and baby? Well, if we're concerned about it or we don't have any data or whatever, maybe we shouldn't. And I get asked about these weird cosmetic procedures all the time. And I think, wow, you've just had a baby. How old can you be in terms of doing this? You need this procedure. And I can't tell you that it's safe. In terms of doing that. Half the time I feel like their mother in terms of doing that. But anyway, point being, risk benefit, it's always in my head. And is there a safer alternative that would work for the woman in terms of doing it? And I actually think the woman is the most important person here. Of course, she cares deeply about how her baby is doing, and so do I. But you know, you can't have people suffering. You can't have people. A sick mom is not helpful to the baby, whether she's pregnant or breastfeeding. And then always, even when I think something's really low risk, I always explain, you know, timing, which we'll talk about in a minute, to, you know, lessen the amount of milk. And, you know, if you notice something different in your baby after you start to take whatever this is, please call your pediatrician, or, you know, don't ignore it, because everybody is different. Every situation is different. It's just common sense. Okay. So other considerations, the reason I put that was the agent used in pregnancy is because there are things that the baby got a big dose of at pregnancy, and the liver isn't working very well. And so you get the buildup from what they already had in pregnancy that they're, you know, in their system at birth. And then when you start adding to it, through breast milk, you can really get a substantial issue. So for things that have a really long half-life, for example, we might be thinking, you know, maybe we need to be a little more careful. And again, age of the infant. So mother to baby, any baby 2 months old or less, we're a little bit more careful with. Absolutely newborns. And I know you guys deal a lot with newborns, preemies, medically fragile babies. In some ways, if the baby's in the NICU being monitored, actually, you know that they're going to get a side effect or something from it, you're going to know, versus relying on the people at mother at home to be able to do that. But we're really careful. So it's almost the first question. It is the first question when it's a breastfeeding question, is how old is the baby? Is your baby in good health? Was your baby born term in terms of doing it? So, you know, according to one study, 2/3 of adverse drug reactions occur during the first month of age. So, you know, it's a time we need to be very careful in terms of doing it. And then we'll talk about these other things like, is it topical? Or, gosh, I just answered a really interesting question about eye drops used to dilate in terms of doing it, things like that. And again, reason for use. I'm not gonna give someone or tell them not to do a medical thing, but as I said, there are people that are doing things that have very good reasons, I guess not good reasons, that are very important, and things that are not. We just try to work through that. And then I'm always thinking, are there acceptable alternatives? This is particularly true if I'm talking to a provider. And there's something, we'll talk about some choices within drug class. Nursing or pumping, again, makes a difference. Sometimes they can time taking the medication more easily if they're pumping, for example. And is the baby totally breastfed? And I just talked to someone who had like a 15-month-old baby who was still totally breastfed. So interesting. So you never make assumptions, of course, but a lot of times by that point, they'll be, say, nursing in the morning and evening, and easy for us to time the medication in between. Okay, I threw in one slide. One of my areas of interest is conveying risk. And so I've always said you can have the best data in the world, and we don't always, to be honest. There's still a lot to be learned about both pregnancy exposures and breastfeeding exposures. But nonetheless, you can have the best data, and if you don't know how to convey it, then what have you done? I mean, you're not doing any good. So I will say that there are some old studies looking at that people come into a situation with usually high degrees of anxiety. They tend to overestimate the magnitude of teratogenic risk, which is risk in pregnancy, but I find it to be true of breastfeeding as well. And so are their healthcare providers. They're very medical legally concerned. They don't want to harm anything. But the point is that breastfeeding is good for the baby, and that you can harm the mom and the baby by not proceeding with the breastfeeding either. And then I will say that our data can be limited and contradictory, and we just live with that. We try to help with that. And again, I find, because I just explained to someone, there were a couple of medications that there was no data. people either think, oh, no data, no problem, or more often they think, no data, huge risk, we can't do it. Whereas often the answer is, time your nursing, monitor the baby, think about what possible side effects you might, can use common sense too sometimes. Anyway, just saying, be careful in those situations and think about it yourself when you're thinking through something that that there's just a knee-jerk response to no data. And most of us tend, I will always say, there are very few genetic counselors that love to take risks. So I will sometimes tell a patient, well, my proclivity is to lower risk. You sound like yours is too, or whatever we're talking about, because you called me and we're talking. But, I think we can self-identify too in terms of that. Some people take a lot of risks. Oh, my favorite. What we say to cats. Well, Fluffy, you clawed the furniture for the last time. I'll not tolerate the behavior anymore. And here's what they hear. I think my cats hear more than this. And I'm not saying our patients are cats in terms of doing it. But I do think, and it's a whole different talk, but it's really interesting how we say what we say and why we say what we say and how they're perceived by our clients. So, enough said. So I had to put in 2 slides on conveying risk. Okay, so let's talk about basic concepts. And I'm thinking maybe these will be familiar to you. We are not going to go through in great detail, but Philip Anderson has a great article on this. It's one of the first things I read when I started. I thought, oh my God, if I have to be considering all of this. But there are some things that are helpful, which are maternal serum levels and the timing of the serum levels, roughly speaking, we'll talk in a second about that, roughly speaking, that for short-acting drugs, that things will peak in milk half an hour, something like that, after they peak in the maternal serum, so it's helpful to know that. The amount that's protein bound, again, if it's highly protein bound, those proteins don't cross into breast milk very easily. They don't cross placenta either, by the way. And so you get less of the agent that would end up, say, in breast milk. And then some other things that I often do not use, like pH and lipid solubility, but I know that Hale and Anderson do. Half-life of the medication, mostly I'm paying attention to things that have a really long half-life, particularly in a very young baby. It's going to be around for a long time in the mom, and then the baby who has a not very mature liver yet, it's going to hang around even more, and you're going to start to see additive effects. And that's often where you see side effects, not the first day, but after a while. How long is the mom going to have to take it? Sometimes they'll take it for a day or 2. They may even decide to use stored milk and pump and discard during that time. And I always say breast milk is like liquid gold, but sometimes if there's something you're really worried about, you might try a strategy like that. On the other hand, there are a lot of things that people are going to take day after day after day for the duration of breastfeeding, in fact. And so we're going to need to be thinking a little differently about that. Bioavailability, something we do all the time. There are a bunch of things that aren't absorbed very well from the maternal gut into her system. They don't get into her system. They don't get into the breast milk. And B, the baby, even if they do, the baby's not going to absorb very much through the milk. There are a whole bunch of things like that. It saves our bacon all the time in terms of doing it. Let's see, impact on milk production. We'll talk about that. So it's something you wouldn't be thinking about in my pregnant patients, but we have to worry about in breastfeeding. So there are these concepts, you'll see them, Hale in particular uses things like relative infant dose in terms of doing it. So the infant dose divided by the maternal dose times 100. We just did this, in fact, with a high dose valacyclovir case in breastfeeding. We did go back and look at the amount that the baby would have gotten through milk and compare it to what the dose that you might give the baby, because you can give babies valacyclovir in the NICU. And it was, even though the woman was a very high dose, much higher than typical, it still didn't turn out to be what the baby was receiving. So sometimes those are unusual situations, but you don't want to stop breastfeeding if you don't have to. And, we monitored the baby, but so sometimes we're thinking, and we're comparing that back to what the World Health Organization says: anything with an RID less than 10% is unlikely to harm the baby. But that's not true. If it's really toxic or really sedating, or then I think 10% is a lot, actually, for a little, say, a 2-weeker or something. So everything, whatever. It's variable in terms of doing that, but you'll see people making an effort. The Europeans that I met at this meeting this month have a new breast milk bank, and which is interesting. And they are actually working on antihistamines first, which is interesting. But they're gathering on a variety of things, and I think we're going to know there are an awful lot of things we actually have no idea what the relative infant dose is, or even if they pass into milk. So there is a breast milk bank at UC San Diego, and then Hale has one too, but there aren't very many in terms of doing it. If you have a patient on something interesting, as we say, interesting, you might consider whether or not they're interested in donating milk that we could look at, and it has to do with, when they take it, and then gathering milk a certain time afterwards in terms of doing it. Honestly, our kind of gold standard ones are when they actually get blood levels on the baby. And we do that sometimes. We are more likely to have the woman willing to give us her blood, so we at least know what her levels are. But we do get baby levels sometimes, because the rest of it, we're just relying on monitoring for symptoms. So it's our life. I am not going to go into this, but needless to say, the mom has to take it. And let me say, in some of our old studies, they were done, and in fact, some of the European ones are done on prescription, but not on whether the person actually took it. We have more trouble with this in pregnancy than breastfeeding, but they're monitoring it, but the woman never actually took it. Or she took it wrong. She took 3 times the dose she was supposed to take, or whatever. So anyway, the point is, the maternal dose is kind of a representative for actually what she's going to get. We'll talk about that in a second too. And then it has to get into her blood, reach the breast milk, be absorbed by the baby, end up in the baby's bloodstream. So that's where those things are. That's from Philip Anderson, an old article, but a good one. Okay, so problems. Well, as I mentioned, sometimes really the small amounts are a problem. And so that's why you don't use that 10% cutoff thing. We're going to talk in a second about pharmacogenetics, and then the difference in bioavailability and liver metabolism. Always, 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 you're going to take the infant's age into account. So that tells you, again, the maturity of the liver, the renal system, how well they'll excrete and metabolize and excrete the drug. Also, are they completely breastfed? And so, gosh, I answered something where there might have been some side effects, but the baby was 9 months old, taking some solids and other foods. It was not the sole source. Milk was not. So don't worry as much. And then remember, occasionally there are things like allergic reactions and stuff you have to worry about that are not dose related. Okay, pharmacogenetics. This is the other clinic I do, which is one of them, where we see people who are either on a lot of medications and they don't think any of them are working, or they're getting a lot of side effects from just even a starting dose on something. And so we do some testing both on the receptors for the medications. These are primarily antidepressants or pain meds or things like that. And then we also look at the CYP, the genes that control the liver enzymes, and are they a slow metabolase or intermediate or ultra rapid? And so because we don't, I mean, someday I think we're going to have this and it'll come up in Epic before we prescribe and it'll say, start low, go slow, or this patient's more likely to need a higher dose and faster, or try a different category, different drug class because it's not going to work very well on this particular patient. And as I said, we can already do some of that, but we're not quite there yet for Epic. Nonetheless, you always need to be thinking that we're talking about on average. So if even when I have good data, it's on 100 women, not on that particular woman or that particular baby. Having now done this clinic for 4 or 5 years, it has made me ultra sensitive to the fact that we are generalizing. We are not dealing, unless somebody tells you they've got a bunch of symptoms or whatever, we are not working with people that have had this kind of testing done. So you're just, on average, here's the amount in milk. On average, this hasn't bothered babies. And that is why even when I think something is very low risk, I always build in the monitoring or, so it would just, I've had people ignore they told us it was not much in milk, so I didn't pay any attention when the baby did blah. And it's like, no. So never forget, you're dealing with a unique set of 2 organisms in this case, in terms of doing that. And some of the really sad cases that have happened, like with pain medications, have to do with people that have abnormal metabolism of their medication, codeine in particular. So interesting, huh? Okay, so which brings me to my favorite strategy, or one of my favorite strategies, and I'm sure you guys all use it, but I ask most patients who call me or talk to me about breastfeeding exposures if they've been taught to time their nursing, and they don't remember being taught that. So I think it is something that almost no matter what you take, you aren't intending to give it to the baby. And so I think one of the ultra cool things is that things move in and out of milk based on maternal serum levels. So when the maternal serum is high, relatively soon the amount in milk is high. Then as the woman metabolizes the drug, the agent moves back out of the milk into the serum, super cool, where she metabolizes it. And so there's less, no need to pump and discard. I had some poor soul that I forgot to mention the no need to pump and discard, and who was trying to pump the amount out of her body to lower her amount. I know. So we always need to be very sure. Now I just always say it in terms of doing it. Okay. And so basically, nurse first, take the medication, defer nursing until past the peak level. And sometimes I'll say, if you still feel it in your system, like it's a pain med or something that makes you feel dopey, then too soon to nurse. In terms of doing it, that's kind of giving you an idea of what that person's pharmacokinetics are actually in terms of doing it. So timing, even with something that's pretty low risk, I guess I wouldn't have to time acetaminophen, but practically everything that ought to probably be timed this way. Of course, this works better for short-acting drugs. And I will say the last one I answered at a half-life of 40 hours. I mean, it's not going to do you, and it was a psych drug. It won't do you any good, mostly. I suppose you could still do it, but really, really, really long half-life is not going to help you. But a lot of drugs will peak in a few hours. And for a newborn, that might be hard to do. I do tell people that it's most important if you're seeing side effects or some other thing, because it's a great strategy. Okay. So minimizing infant exposures, use short-acting medications when possible. Now, the reason we don't is because it's easier for patients to, and they do it more reliably, to take it once a day or something like that. But it does make it more difficult in breastfeeding to time around it. So it's most important when we're worried about the side effects. Watch out for active metabolites. Again, this is back to that pharmacokinetics, which is that you're thinking about the prodrug, but then you're thinking about what it's going to metabolize to, which is often the drug that has the effects, the side effects. So just watch out. In fact, when you can, you want to actually use a drug that does not have active metabolites. It's going to be easier. And all the time, I suggest an alternative route of administration if it's medically appropriate, like topical, inhaled, or whatever. So rather than take a steroid, use a steroid nasal spray or steroid cream or whatever. It depends on what you're treating. Of course, you don't undertreat the woman in terms of doing that. I'm not suggesting that, but when you have an alternative, why not? You just get way less into her system, less into the breast milk, less likely to cause a problem. And then sometimes within a class, there are drugs that pass well into milk and some that don't, for many of the reasons that were on that slide earlier in the thing. So for example, a bunch of these, we're really careful about actually later in pregnancy and also at delivery, and in neonates of the beta blockers. And then there are some that are kind of intermediate, and then, some that are pretty low risk, not much gets into milk. In particular, propranolol turns out to be the one that's least, the old Inderol. And I recently had a patient who said, "Oh, I love Inderol. It works the best for me." They took me off of it for pregnancy for some reason, but she was having trouble with her blood pressure. And again, we don't tell people medical stuff that they, it's not really our job. But I said, "Oh, well, talk to your doctor about that," because, yeah, she was on something that there was no data on at all for, that's one of the calcium channel blockers, which is not the end of the world, but no data. And she loved propranolol. Well, if it worked for her, there's not very much of it in milk. It's a good choice. Okay. The other thing is, and I actually tell patients this, there are a whole bunch of things we don't have enough data on, but I had a patient call me yesterday about she had a broken bone and she needed to take pain medications, and so they'd given her acetaminophen, ibuprofen, and oxycodone. And so I was talking to her about the fact that there's hardly any Tylenol, acetaminophen, or ibuprofen in breast milk, but also, as she knew, she could give it directly to her baby. And we worry lots less about a baby getting some in milk if you could directly give it to the baby. So again, do we give babies aspirin? No, we don't anymore because of Rye syndrome and things like that. As a consequence, medium to large doses of aspirin in the mother need to be approached very cautiously. So it's the same thought process in reverse. You don't give those medications to a baby, so you don't want them to get very much in milk. That makes sense in terms of doing it, and then vice versa. Of course, be careful with things that reduce milk supply, and always be thinking about, are they getting a clinically important dose? And you can often, of course, the people in the labs hate me when I say, "Could you give a drug level on that baby?" But it can be done. It can be done. And here's some examples of things that might reduce milk supply. So they're not used very often in breastfeeding women, and so things like ergotamine, bromocriptine actually dries up your milk. Interestingly, pseudoephedrine, a decongestant for some women, and even with well-established breastfeeding, and they've called me and told me, it can bring their breast milk, people here are breast milk production to a halt.
Is that also true of like your loratadine and antihistamine? So
They carry warnings for that. Pseudoephedrine just seems to be the most. That phenylephrine, the FDA says it doesn't work. Oral phenylephrine doesn't work as a decongestant. I'm just waiting for them to take it out of cold medications. People brought it to the attention of the FDA maybe 4 or 5 months ago. If you Google it up, you'll see. And the FDA admitted they knew that it didn't work as a decongestant. We've worried because in pregnancy, it can make people hypertensive and perhaps it is absorbed and it works as a nasal spray in your eyes, but apparently oral is not a good decongestant. In fact, the way it was stated in the article doesn't work for as a KT. And the only reason we have phenylephrine is because they were using pseudoephedrine to make meth. So now that's why it's behind the I digress, in terms of doing that. So anyway, just something to think of. And particularly decongestants plus antihistamines.
They're doing BLS, so.
Doing what?
Basic life support.
Shaking hands at the
Sorry.
moment.
That's okay. Well, interesting. Decongestants plus antihistamines in particular carry warnings about reducing milk supply. Estrogens, progestins, one of the reasons we wait a little bit to get people started on some of their contraception is that it may interrupt milk supply. Nonetheless, I have a bunch of patients that got pregnant in the first 2 months after. I try not to say anything, when they call. It does suggest, you can actually start the progestins earlier. You probably wouldn't use an estrogen progestin combo pill. Okay. So to start,
Question.
of course you may.
So, you talked at the beginning about, that some people will use the relationship of, if I can't take it when I'm pregnant, then I shouldn't take the medication when I'm breastfeeding. How would you counsel them on the reverse? So saying I took it while I was pregnant, and then the assumption that it is safe
Yeah, I know.
while breastfeeding.
We really deal with that all the time.
Yeah.
So can they hear you? You asked that question?
Yes.
No, I have to repeat. Okay. So the main thing that we run into are reduces your milk supply. So you just say, we aren't worrying about your milk supply in pregnancy, and B, sedating things. Actually, I should say there's C2, but B, and you really do have to worry about that. Can the baby move their nose away from their blanket, or even so it's back to sleep? They don't always sit. You just don't want a really sedated baby, and they won't nurse very well. You'll often see reduced weight gain then in a baby that's sedated. And although it sounds delightful that your baby would be sleeping all the time, it's not what you want.
Right.
It's a really bad idea, actually, in terms of doing that. So anyway, that would be and then the third thing I'll explain to people is that when you're pregnant, you are metabolizing those drugs for your baby. And then look at your baby has this little liver and it's just coming up to speed for those first 2 months for sure. And even after that. And so you're not doing it for the baby anymore. So we need to be a little more careful. So that's kind of how I explain that in terms of doing it. I find most patients appear to know or nod their head and say they understand. So
Yeah.
here's the AAP. This is the old list. They would publish this every 3, 4, 5 years. Most of these things are still not a very good idea. And they're either because they're really toxic, or they do something to the baby's immune system, or radioactive compounds, never a very good idea, in terms of doing that, or things that might go to the baby's thyroid or whatever, really sedating things. Yeah, none of that's really changed. Interestingly, these are the published duration for interruption of breastfeeding. One of the more common things I get called about is marijuana. Now that it's legal in many states, so I'm answering the national hotline a lot of times. Well, marijuana remains in your body at least 4 to 6 days, but in small quantities in terms of doing it. And it can be around for 42 days or whatever. I mean, long time depending on who you are and chronicity. So if you use a lot every day, then you're going to store more, and it's going to be more of a problem. Than I get people that say I went to a party and I failed and I used some marijuana and now I want to breastfeed my baby. When can I do it? And so you can see that the general recommendation is 24 hours. You could try to calculate it out. We find these to be very difficult questions because basically the current recommendations are not to use marijuana when you're breastfeeding, but an awful lot of people do. I read an article yesterday about, I think people think if it's legal, it's okay. But, we don't recommend you breastfeed immediately after drinking alcohol either, and it's legal. So, there's that, alcohol. I tend to use 2 hours per drink, sometimes 3 actually. It depends on whether the patient knows what a drink is. Because, I got this patient that had White Russians. Well, there's like 3 shots of alcohol in a White Russian. So, and a glass of wine is 5 ounces. Well, that's like a half a cup. Well, those wine glasses hold like double that. So, so that's why you might have someone who wait a little bit longer. And again, remember, everyone's going to metabolize alcohol differently. I tell them, if you still feel drunk or woozy, not the right time to breastfeed or pump or whatever in terms of doing it. So anyway, yes, we answer these, we try in terms of doing that. The real thing is you can shoot yourself in the foot. They used to say you couldn't, I put a slide in here, you couldn't smoke tobacco and breastfeed. And then some genius looked at the babies who were breastfed, whose moms were smokers, had less respiratory problems because of the immunoglobulins and the other good things about breast milk. So they were like, why? So the current recommendations are, don't smoke more than half a pack a day. Don't smoke just before you breastfeed the baby, and don't smoke around the baby, all of which makes sense to me. Not the don't breastfeed if you smoke kinds of things. So, we do get smarter. That was American Academy of Pediatrics. Got smarter. Okay, moving on to hot topics. Depression. At least 1 in 7 women, probably 1 in 5 right now. Women of reproductive age have depression. Not all are on an antidepressant or anxiolytic, but an awful lot. And so it's probably the most common question I ask or I answer, certainly during pregnancy, but also during breastfeeding. And I just tell every woman, almost the first thing out of my mouth is, however you want to look at it, you're important, but treating you is going to help your baby or your breastfed infant or whatever. I just think women will sacrifice a lot for their babies and their children, but not treating themselves in these situations is not the right way to go. So I will often phrase it in that way. You're helping your baby by, or your other children by doing this. When of course I think women are important and women shouldn't suffer and in terms of doing this, but yeah. So, issues. Again, I mentioned, is someone on it during pregnancy? Often, many of the psychiatric drugs, many of the SSRIs, certainly the SNRIs like Effexor and Pristiq, babies have fairly significant issues with newborn adaptation. And sometimes they'll spend a little bit longer in the hospital, but it can take a while for them to get it out of their system. I always say, these are drugs that people don't feel very good when they discontinue them rapidly that are adults, and babies don't enjoy it either in terms of doing it. So we just need to be careful. It can interfere with the breastfeeding a little bit. There is some of these medications that show up in colostrum or whatever, but it becomes more of an issue if they're on a high dose. Like I had a patient on 80 milligrams of a tricyclic. I mean, really big doses. The baby was struggling with the newborn adaptation issues, and there can be a lot in breast milk when it's a high dose. We need to take it seriously. Most of these things are, not high risk, but they can have some risk in terms of doing it. And again, infants metabolize and clear drugs at different rates based on their age and also on who they are in terms of their pharmacokinetics. I will say we keep studying, and I don't want to raise an issue that I don't think is a big issue, but we still don't know about the neurocognitive things about use in pregnancy, much less breastfeeding. I think the pregnancy ones are more important. We have seen some, well, you have to remember, anxiety and depression are somewhat genetic. So the baby will have inherited some genes for that, perhaps. I always tell my kids I passed the good with the bad. I tried my best, but you can't pick through them. The issues, for example, there was a study out a few years ago that women who took antidepressants in pregnancy had an excess risk for babies with autism, with neurobehavioral kinds of things. I don't think the data is overwhelming for that, but I think that we don't know. And there are some studies that suggest that, yes, and some studies that are not as sure. It's true of the anticonvulsant medications, which get used for mood disorders too. They may have, well, some of them definitely, like valproate, definitely have cognitive things. So then the question has been, we don't use it, Depakote, it's valproic acid. We don't use it in pregnancy. Can you use it in breastfeeding? Poorly understood, to be honest. So we're careful. You really don't want to deal with neurocognitive things if you don't have to. So if we don't even understand it clearly in pregnancy about a lot of things, then is there any risk in breastfeeding? Well, probably low. I will say this is something we don't know yet and that people are doing long term. There's a big, there are a big series of studies in Europe right now going on the neurocognitive impact of medications in pregnancy and breastfeeding. So I think we will know more. They have big numbers over there. They were not looking, they were just looking at birth defects and, sort of obvious things. They are now refocusing. We've done that here for a long time, and Toronto's been looking at neurocognitive things for a long time in their research. But I would still say this is something we don't know. Do I worry someone about this? Not generally, unless there's a lot of it in breast milk or it's a particular, bad actor. Like we actually suspect that it might cause problems. So anyway, just something you just have to know. There are things we don't know yet. We will someday. So medications and lactation. Anxiolytics are predominantly benzodiazepines. They use less of these now than they used to. One of my first, I was really a young genetic counselor, was a pediatrician who called me and said, I have this baby who's really sedated, and the mom is taking, it was clonazepam, it was a benzo. Do you think it's related? And I looked it up. We didn't have very good data. I looked it up and I thought, yeah, I do. Smart pediatrician. This was a long time ago. And I said, is the woman able to just go on, say, Zoloft or something to try to, which will also somewhat treat her anxiety, but wouldn't cause that kind of sedation. And sure enough, the baby woke up and started feeding. In terms of doing that, that pediatrician noticed that predominantly the baby was losing weight and not waking to feed. So interestingly, our primary providers are super sharp. They pick up on stuff that I've learned lots of what I know from them in terms of doing it. Again, in pregnancy, benzodiazepines may be what we call behavioral teratogens. They are certainly in laboratory animals. Are they in humans? I don't know. So that'd be like Valium or whatever. If they try not to use it day after day after day in a big dose, unless, you'd really have to monitor the baby for sedation. These are really sedating often. And they often will switch into an antidepressant if it'll work. You use, and antidepressants a lot of them are acceptable. Note that Zoloft and Paxil have the lowest amount in milk. Paxil, we don't use very much in pregnancy. There may be a small increase in risk for heart defects, and it does give you a lot of problems with newborn adaptation. So they often will try Zoloft, but if it doesn't work, it doesn't work.
Lots of Zoloft. We see lots of Zoloft.
Zoloft's a really good choice. It doesn't give you any more birth defects or problems with newborn adaptation than any of the others, which is, low risk for birth defects, some problems with newborn adaptation, 1 to 2% or something of that. In milk, it's low. I don't know if I've ever seen a baby that had adverse effects when the mom was taking sertraline, Zoloft. Does that mean you shouldn't still be careful? Well, of course you should be careful. Well, they have the tremors, correct, you were doing after birth, that's the withdrawal. but I've never seen it from breastfeeding, like say at 4 months or something. No, okay, good. I was gonna say, if you've seen it, you should tell me. No, they'll have issues with newborn adaptation, as they do from almost any antidepressant, but less than Prozac. They have a lot of issues with newborn adaptation. And by the way, Prozac, there's a fair amount in milk. It's not contraindicated, but you'd want to, use some caution with it. Try not to go way up on dose. And then antipsychotics, I listed the best studied ones of the newer, the atypicals. Watch for sedation, and some of them either increase or decrease prolactin. Some of the old ones increase prolactin, which would be good. Abilify in particular can reduce prolactin. Lithium used to be contraindicated in breastfeeding. Excretion in milk is variable, but can be significant. Babies can show a bunch of side effects, both affecting their thyroid, which is important for growth and development, and also sedation. And so their babies have a lot of difficulties in the newborn period sometimes because the mom's been on lithium. We do get serum levels. We will get thyroid studies beyond the newborn studies. Just a note that women's clearance changes dramatically at delivery. So they will keep upping the dose of lithium during the second and third trimester. Often they'll need to, not always, but they'll often need to. And then boom, they need to really change the dose right after delivery. And so if they're not doing that, she may be on a lot of lithium, there would be a lot in milk. So the current things are a decision about, is this a woman who's highly, committed to breastfeeding, and do you have a pediatrician and parents who are willing to monitor the baby for sedation and things like that. So, and is her dose reasonable in terms of doing it? So it's not contraindicated anymore, but it's one of those used with caution ones. I do want to mention, every once in a while, I talk to somebody about non-medication strategies, but there are two pretty good studies, one on depression and one on bipolar depression, where they combine, when they looked at the exercising in front of a sun lamp or a light source, or just a light source, compared to, I think the first one looked at fluoxetine. And I wouldn't be mentioning this if it wasn't the case that it worked pretty well. In fact, it worked better than fluoxetine 20 milligrams alone. But together, I will say they worked even better. So for a patient that's terribly ill, are you going to suggest that they drop back into light therapy? No, probably not. But I will say for people that are kind of mildly depressed or whatever, and I find the psychiatrists know this too, people have to, kind of use it repetitively and effectively. But I've occasionally suggested exercise or other kinds of things. So again, it's a highly motivated patient. Maybe the baby's showing some side effects, I don't know. And they might want to try, just to remember that not everything has to be a medication. Of course, in anybody that's suicidal or, anything like that, we're really careful with medications, nor do we want them to suffer through something. It's just that maybe they might try this rather than going up on dose or whatever, just to keep thinking about that. So I think it's really interesting. And like I said, I think psychiatry is really interested in this if they can get patients to do it. Well, I think our patients are highly motivated. It's, do they have the time, with a new baby and whatever. Okay. Treatment of allergies. So older antihistamines are sedating. Again, this is that thing. Would you give an older antihistamine, diphenhydramine or something like that, to a baby? No, no, you would not. We don't treat allergies in babies that way anyway, and they're pretty sedating. I will say many of the new ones, there's not much in milk. So I know off the top of my head that loratadine and Allegra, which is fexofenadine, there are small amounts in milk. You're always welcome to check with me or look in the databases, but because they keep coming out with new versions of it. Again, just a reminder that antihistamine decongestant combos can reduce milk supply. I actually discourage decongestant. I mean, all they can buy on the counter is that phenylephrine anyway, and the phenylephrine doesn't work. So we might as well not use that combo. And then I do have a lot of patients that, of course, if they've got asthma, they should treat the asthma, and you don't absorb very much from inhalers. Flonase and let's see, so there's fluticasone and mometasone. They're both something like 4 or 5%, maybe 6% absorbed through the nose. Again, I had a patient that used them every 4 hours, and you're supposed to use them once a day. So you always want to reiterate what the, patients use things in different ways. They don't read the labels because the labels are microscopic. Okay. I put this in just because I answered a couple of anesthesia questions in a row when I was ready to talk. And I thought, oh, let's talk about anesthesia. And that might be dental anesthesia. That might be getting your tubes tied. That might be having a procedure for something or whatever. And so remember, of course, they're going to use a combination. They're going to use a pre-anesthetic group of things that's often something like Versed or propofol or something like that. So you need to be thinking about that. Then general anesthetic agents, let me say, nobody's waking up if they're still in their system. So, and they're not nursing the minute they come out of surgery or whatever. So if they're awake and they've been out of surgery for a while, that nitrous or whatever they used for the general anesthetic is usually gone. And we don't need to worry about it. And remember, things are moving back out of the milk into the woman's system where she can metabolize it. Then Versed has a short half-life, and it's one of the reasons they use it. So there's the 2 expert panels recommend waiting 4 hours after a single dose or 6 to 8 hours for a newborn or preterm. Fentanyl has a short half-life. We're lucky. IV fentanyl. Let me say, this is not abused fentanyl, fentanyl patches, or any of the other things, but professional fentanyl has a 2 to 4 hour half-life, and like many of the opioids, does not pass into milk very well. And again, propofol, I worried about if you used it all the time, it's stored in your fatty tissue, but not very much with a single episode. So again, what I say to people is, wait a bit, especially if your baby's very little. And if you still feel dopey, you're the canary in the mine, not the right time to start. Use stored milk or whatever. And, often women need a break. Like if they just went through surgery, maybe the baby could have a bottle of stored milk or something if they had to, in terms of doing it. So one of the more common things I answer are over-the-counters and herbals. And just a couple of rules of thumb. Just because it went over-the-counter doesn't mean it got studied in pregnancy or breastfeeding. In fact, many of the it's more dependent on safety for the adult that takes it or whatever. And many of them got grandfathered in. They were put out in the 50s or 60s before they required the kind of testing that we want on this. So there's often very, very poor data, and then patients don't take them the right way. And so we'll talk about the problems with herbals. They don't contain what you think they contain, and they have other things in them. So so they're not your, I always say, if someone's really sick, prescribe something. You know what they're getting and what the dose is in terms of doing it. Herbal products vary greatly, like how wet was it during that season. And so the thing that you need to remember is that the FDA does not regulate herbs and supplements. And companies spend millions of dollars lobbying to keep that true. They're called nutraceuticals. And I guarantee you they aren't regulated. That means they don't have to prove that they're generally safe and effective. And they, you have to have like 25 people whose livers are destroyed by it or something before they go back and say, ooh, maybe that needed to be regulated, but the FDA can't regulate. That's why they don't regulate, a lot of things actually. It's all legislatively determined. So not only do they sometimes not have what they're supposed to, or because of that, it's impossible to study them. Impossible. Like the only reason we know anything about St. John's wort is because it got used as a prescription drug in Germany, and we have a little bit of data because we have no idea what people are taking. But remember 2 other things. Sometimes they're contaminated with pesticides or lead or arsenic or other things, seriously. And that is not what you want. And B, things, they may interfere with prescribed medications, and patients don't think about that, but St. John's wort was notorious for interfering with oral contraception. I had a bunch of patients get pregnant taking both, and they thought, oh, it's natural. How bad can it be? Well, I don't think it's a huge teratogen. It's not, still not studied very well. So most of the time, the answer to supplements and herbal products is probably not your best choice. We're not going to have data that's going to tell us on your particular product whether it's safe to take in terms of pregnancy or breastfeeding. That doesn't mean it's a hazard. It just means if you want me to tell you I think this is okay, I'm not going to be able to. And it's going to be a long time. They're going to have to change it over to being regulated so you actually know what you're getting and you know that there's not this other crud in it. Commercial herbal teas. So the way I answer these is if you are using them for a medicinal purpose, and in particular, like, you know, but even in the grocery stores, occasionally they sell these medicinal ones. But, you know, if you're using tinctures, if you're doing that kind of stuff, it's probably not studied adequately in pregnancy or breastfeeding. So you want to avoid things with potent pharmacologic preparations, you know, things that are, you know, some kind of small amount of, you know, lemon or cinnamon or whatever. You know that there's problems that the cinnamon is contaminated with lead, but I've not seen that that was true for just your kind of over-the-counter teas. So, you know, you never want to be so restrictive that people can't do anything, and then they feel like, oh, I'm not going to breastfeed anymore because it's too inconvenient. But these herbal teas can be, the medicinal ones can be medicinal, and you need to count them like a medication. So then you better know something about what's in them, and frequently they have not been well studied with regard to breastfeeding. And you need to know that that's really what's in it. Protein shakes are another one. Doesn't that sound benign? Who wouldn't eat a protein shake? And some of them are just protein shakes. Again, are they regulated? No. But, you know, there's certainly reputable brands, and I make people read the label. Is there just protein in them? And when I ask, frequently, the reason they're taking it is they need energy or weight loss, or they're depressed. Well, then there's something else in them usually, because protein itself isn't going to do that for you. And so some of these are very expensive, very exotic things that have lots of herbal products in them. And so some of them either, you know, are going to really agitate your baby in terms of doing that. Some of them are going to sedate your baby. Some of them, there's junk in them. So it isn't that all protein shakes or all nutritional shakes are bad, and some women have trouble getting in enough protein in their diet. Most women don't. But just remember, I always ask the next question, what's in it? Also, just watch out, you know, some of them have like 1,000 times the RDA for certain vitamins and stuff. Most of that's not a problem in breastfeeding. It might be in pregnancy, but it might not be a good idea either in terms of doing it. We have a mother to baby, and we'll talk about that resource at the end, a fact sheet on herbal products and a fact sheet on protein shakes that I hand out all the time, because it saves you from going through that whole long explanation that protein is okay, but what else is in it in terms of doing it. So again, just think anything that has known adult toxicity, damages your liver, damages your kidneys or whatever. I mean, you can just guess that's going to be a bad idea. Things that stimulate GI motility, like some forms of aloe. Some forms of aloe are very stimulate your GI system a lot. This is generally not what you're looking for in your baby. They're very poorly studied. I just got asked about buckthorn. And when I looked it up, it was called purging buckthorn. Bad. You know, you just know, you know, like, oh dear. Senna, things like that. They are probably excreted in breast milk. There's certainly reports of babies having GI issues after getting it through milk. So nobody really knows, but maybe not. And then again, there are some things that might have the effect on the thyroid. I mean, you could just guess these things are going to be potentially contraindicated in terms of doing that. And more commonly, what someone will ask me about is something with like valerian or especially kava kava, which is sort of benzodiazepine-like, and you just really don't want it. Too sedating, no, no, no. And you know, there are a lot of people with anxiety. Being a new mom is anxiety producing. I am very sympathetic to that. Then we need to treat these things like the real medications that they are, and they need to be prescribed and timed, and the baby watch for side effects and the whole deal. Watch out for things that have estrogenic effects, which can reduce milk production. In particular, black cohosh and chaste tea, but there are other things too. And again, not intended for use in infants or toddlers, basil, et cetera. Now, let me say that you can eat small amounts of spices, something that might be in your diet, you know, like basil or something, but it's when you're taking it medicinally or as a supplement that we worry. So what about galactagogues? I have to say, people in the biz are kind of skeptical of them. It doesn't mean that none of them work, but they're kind of skeptical. And you all know that the first answer, and it's one I give to patients, is, you know, push fluids and call your lactation consultant. It is to nurse more frequently in terms of doing it. So a lot of people need to talk to their lactation consultant about behavioral things that will help with their milk supply, and they may just need the reassurance from their pediatrician or their pediatric provider that their baby is gaining weight adequately and whatever. The last woman I talked to who was worried about her milk supply, I said, well, is your baby gaining weight? It's like a 3 or 4 month old. And she said, oh yeah. I said, well, then, you know, that's reassuring. Talk to your pediatric provider. But so I will say the data is pretty limited. And interestingly, they don't very often look at the baby long-term. In fact, almost none of them do. Like, is there any possibility of harm from it too? So we're kind of frustrated in the sense that we're looking at, is there something in the milk, not that to increase the milk, but that in the milk that might cause long-term damage to the baby. Anecdotal reports show widely variable results. So, you know, I'm not saying that none of them work. I'm just saying very poorly studied in terms of long-term thing. And here's probably one of my favorites, ABM clinical protocol number 9, use of galactagogues in terms of doing it. And I gave you the citation in case you want to go take a look. In general, professional literature on galactagogues is not very, there's not much of it. Okay, fenugreek is the one I get asked about most. You can tell it's in milk, let me just say, because it makes it smell kind of maple syrupy sometimes, women will tell me, in terms of doing it. Notice that people also take it to lower their blood sugar. So people with type 2 or pre-type 2 diabetes will take fenugreek to lower their cholesterol and lower their blood sugar. You know, do I know what that means in terms of the baby? I don't know, but you know, it's not an inert agent. It doesn't just try to stimulate breast milk in terms of doing it. It does, it depends, of course, tremendously. Some of it has coumarin, it is oxytocic. It is contraindicated in pregnancy. In one study, milk production doubled, but there were reports of, in a couple babies, GI bleeding, colic, or diarrhea. So I just find very, 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 very poorly studied. And remember, because these products aren't regulated, you don't know what the actual ingredients are in the particular one you're using, because you don't get the purified form. Am I a big fan of big pharma? No, but they are required to be regulated and they have to use a purified form. That is not, this is a wild west in terms of supplements. Blessed thistle low toxicity, but there are few hypersensitivity things that can have a laxative effect, really poorly studied. Phenyl estrogenic properties, as we said before, that could actually suppress lactation. I get patients that are told to do all of these things, or they find it on the internet or social media. And then Chase Tree, again, inhibits prolactin, it can decrease milk. So you're getting the, there's some stuff like mother's milk tea or whatever, and it'll have some of these things in it that I think are gonna actually do the opposite of what someone is hoping for. So anyway, use with great caution. Again, there just needs to be some more data on this. And honestly, we should regulate these products, but we don't. Okay. Vaccinations. The vast majority of vaccinations are acceptable in breastfeeding. Breastfeeding should not be a contraindication for anything except a couple of things that are the live vaccines, and your patient won't be getting it very often, like smallpox or yellow fever. I think Japanese equine encephalitis is live too. I mean, these are not things that anybody is getting very often in terms of doing it. All the other standard ones are very acceptable. And the CDC just says blanket, no contraindication to them. Monkeypox, I forgot. Monkeypox is another one that's a live one. So those are not very often given to postpartum women either, but just in case. This is the cdc.gov website, and they run it along with ACIP. I find it very helpful just because it shows you they're acceptable, except just remember the live attenuated ones. Again, there's some national campaigns. We're telling patients right now, COVID vaccine is out. Getting COVID in pregnancy or breastfeeding is miserable. So you should feel comfortable immunizing if you're eligible for it. We get asked about breastfeeding if you have COVID, and we do remind people to wear a mask. You don't really want to give COVID to your baby. It depends on what the actual exposure's been. And sometimes you might choose to express milk or do something like that, or supplement the baby. Some women feel really terrible when they have COVID. Remember again that things to control fever like acetaminophen and ibuprofen are acceptable. They're beginning to know more about things like Paxlovid, but by and large, although we suggest you call and check, many of those things are acceptable for use in breastfeeding. A reminder that Mother to Baby, my parent organization, that's our outreach, has a really nice webpage on COVID-19 treatment, COVID-19, all things COVID, and including a fact sheet at the bottom on this has breastfeeding. And we have, actually I should say, we have podcasts, we have blogs, we have all sorts of stuff. We have been receiving, I have gotten only a few on the most recent COVID vaccine, but I've gotten a bunch of patients that called because they had COVID. East and West Coast in particular. And let me say, so we have stuff on all the different vaccinations, and they do include pregnancy and breastfeeding. Okay, that is immunizations in a nutshell, but we have fact sheets on nearly all of them, and so go ahead and look them up or call us if you need us. Caffeine, well, it passes pretty well into breast milk, but I will say it's not contraindicated. It's just that you might not drink a cup of coffee just before you nurse. In terms of doing it, like all things, it passes pretty well into milk, and it can make your baby have insomnia and be jittery. So not usually what you're looking for. So a little bit's okay, just as it is in pregnancy. Just think about it in conjunction to when you're going to nurse. I was talking before about tobacco. So the fact that we used to say that it was contraindicated, but now it's that we're trying to get people to smoke half a pack or less. This would be true of vaping too, by the way, but half a pack or less, not smoking around the baby, and don't smoke just before you feed, but rather after. I wanted to talk a little bit about marijuana. I will say, as it's become legal, people have increasingly thought that it was okay in pregnancy and breastfeeding. And I will say that hasn't really been true. Or we sure don't think that in our field. Now, does this mean it's a guarantee for intellectual deficits and birth defects and other problems? No. But is it safe? We sure don't know. The thing that I notice most, along with just that it can be contaminated with lots of other things, is that it's up to 30 times more potent. So it used to be that the THC in most marijuana was 3%. And now that it's been legalized in a lot of places, the average is around 30%. And they remove some of, and then when you're vaping, some of it is up to 80%. THC. So in fact, I've been reading articles where people are complaining that it's too strong, that unless you're somebody that's like really just trying to zone out all day, every day, that, doing a little something to relax, they get this incredibly potent product, and it's too much. Well, I don't think people are aware of this. And as a consequence, our data on marijuana in pregnancy and breastfeeding is mixed. But let me say, at least the data in pregnancy is that we see some, with people that use it pretty chronically, that we're seeing some neurobehavioral things, some ADHD, sometimes some learning issues, and definitely increased use of drug use themselves. In these studies that we follow people through 20 or 21 years of age. It is not known as much in breastfeeding. I will just say, if it's 30 times more potent, you could, you need to be really careful because of the potency. And then they have very little data on how much is in milk, say, if you eat it, or you receive it through other things than smoking. So again, the studies really aren't there. But there are some concerns from the pregnancy studies, actually significant concerns from the pregnancy studies on high dose use chronically. Note that THC can reduce prolactin, that it can remain in milk 6 days to 6 weeks. You may recall that slide I showed early on was that you should defer nursing for 4 days. It's really hard to know. If someone is just establishing breastfeeding, I don't know, then they got a little baby and they need to be particularly careful. But I get these stories. I had a single, dose or something. Do I need to not nurse for 4 days? Well, that's going to really interfere with someone's nursing. I think they should wait 24 hours for sure, and then monitor the baby for side effects. It depends, again, dose and chronicity in terms of doing it. All professional organizations discourage use of cannabis in breastfeeding moms. And we have a nice spec sheet, and I had to write a review on developmental consequences of cannabis use painfully. It was 2 of my articles in the past 5 years have been the most accessed articles in our literature. One was on vaccination and pregnancy and breastfeeding, and one was on cannabis, hot topics. And painful. I feel like a whole year to write the cannabis one because the data was all over the place. But yeah. So here's study 1, 8 lactating women, cereal milk samples, and the relative infant dose, 2.5%. They didn't mention the infant. It wasn't clear whether there was accumulation. Here's study 2, 50 lactating women. They provided milk samples. In at least one, they saw this THC 6 days. I don't think you're going to see it 40 days after usually, but that's in the literature. And so, I don't know. There isn't enough data. I know that that Bertrand study came out of Otis Mother to Baby, and the other one came out of Hale. So it is that both groups that have milk banks are answering this question all the time, and there isn't enough data, so they're collecting milk it's not legal here in Nebraska yet, although as you know, medicinal use is on the ballot for this year. Alcohol, again, certainly think people shouldn't have it in pregnancy. I used to do fetal alcohol syndrome clinic. It's a tough deal. So again, remember there's what a drink is: 12 ounces of beer, 5 ounces of wine, or a shot. And for a lot of patients, that's not what they're drinking. I mean, that's not what they consider a drink to be. So, just do that. We have a nice fact sheet on it. Again, this is one of the things I've had women like try to pump the alcohol out of their system, but really so it's always important for us to tell them that it will move back out into their system and be dealt with by their liver. You're just waiting for their own blood levels to go down. If they still feel drunk, it's too early to nurse. Not studied very well, but it is believed that there may be some developmental impact if the baby's getting it frequently through milk. It can also reduce milk production. Okay, abuse substances. We can answer lots of the other ones too if there's data. There's shockingly not good data on a lot of things. I think because they're illegal or whatever, people are not offering up their milk supply or their milk to these banks of things to check. Okay, I mentioned that just because it's over the counter doesn't mean you can use it in pregnancy and breastfeeding, but there are a bunch of things that are pretty low risk. So again, we've mentioned acetaminophen and ibuprofen, guaifenesin. There's actually more than this. Toms, so multivitamins, topical things are pretty low risk unless they're just applying really high, like there's some of the fluorinated, the steroids that are really high potency and stuff. If you apply that to a lot of broken skin or something, you might run into a problem. So nothing is like, people are always asking me for lists, and I don't give very many lists because I find that it depends on, what is the age of the baby, how much are they using, how are they applying it, whatever. I do remind people with topical to wash their hands after. They often forget to do that. And you don't need to get it through your hands usually, but you certainly will get a dose that way. Most topical agents for acne are low risk in breastfeeding. Again, really high dose stuff, maybe not. Likely okay. Again, I mentioned already things like the newer Claritin, Allegra, dextromethorphan helps it. Topical pyrethrins, you would use for head lice or something like that. I answered that recently and someone was using a really high dose preparation and she didn't know she had it yet. Her kids did. So it was sort of like an ick factor where she thought, she'd get something from them, but she hadn't gotten. I suggested she wait till she actually knew she had it and maybe not to use the highest dose thing. But I think pyrethrins are fairly low toxicity in terms of variant. And who would make someone suffer through things like that. So after answering it 5,000 times, probably not 5,000, probably 500, I actually wrote this blog on breastfeeding, treating cough and cold symptoms. It's not really a blog. It's what we call our fact sheets that deal with a condition. So it talks about behavioral strategies, different medications you might use, and then it links to all the fact sheets. So we have one on pregnancy called Sniffles, and then mine, thank God they didn't give it a cute name, on treating cough and cold. And so it's pretty conservative in terms of doing it. You can always add things into it, but I hand this out almost every day. So it's like I just got tired of typing it out constantly or explaining it. So I'll have someone take a look, and then if they still have questions. And so there it is on the Mother to Baby website, which of course is a fabulous resource. I will remind you there are things that you want to be careful, even though they're over the counter or whatever. High dose aspirin. We mentioned already that a lot of the cathartic, Senna, and other kinds of things will cause you to not be constipated anymore, but diarrhea in your baby and sometimes colic-like symptoms. Very sedating things, and there's a whole bunch of sedating things over the counter are generally not a good idea. And that is part of why the older antihistamines, along with the fact that they might interfere with milk supply. Huge doses of vitamins, just very poorly studied. Honestly, some of them, your list is kind of interesting in that it will sometimes limit the amount of a high dose vitamin that actually gets into milk. I tell you, breasts are really cool. But anyway, you wouldn't want to count on it. So call or look into it before somebody takes like gigantic doses of vitamins. And again, most herbal medicines, not always because we understand their hazard, because some of them are, and we don't know what's in them, and they're poorly studied. So just rule of thumb, you can almost answer it. And again, we have a fact sheet on herbal products and supplements. They are not FDA regulated, and they are not well studied. So they're almost always not what you are going to recommend. And every once in a while I see in someone's records or whatever, oh, I told them to go and take blah, blah, blah. You do not want to be that person, because maybe someday we'll know enough about them, but then they still have to be regulated so you knew what you were getting in the bottle. Cosmetic preparations, again, most of them are topical, but you would be shocked at how poorly they're studied. So the answer is generally that topical application of these things is low risk. That's true, but yeah, they almost never get studied. And we do suggest, of course, they don't eat them or whatever in terms of doing it. But of course, they can use cosmetics to wash their hair and, do that kind of stuff. It's the fancy schmancy weird stuff that you might not have to do, and they're often poorly studied. Watch out for things from, it's not to pick on India or China or Mexico, but occasionally they'll have like the really dark hair dyes will have lead in them or something that might actually be hazardous in terms of doing it. Okay, tattoos. I get a shockingly large number of tattoo questions. My favorite, this is going a while back, my favorite one was a woman who called me because I was not from Nebraska, because she wanted to get tattoos on her breasts and she was breastfeeding. I personally thought this sounded like a very painful thing to do. And I just told her, not known that a lot of this stuff would get into breast milk, but not well studied. And if she got an infection, they were going to have to treat it with things that, might cause problem in the baby, or diarrhea or whatever. And that, people had to be really careful that it was sterile and whatever. And if they got sick, they needed to call their healthcare provider. And she said, and I said, really, you should talk to your pediatrician before you do this. And she said, well, I did. And they said I couldn't do it, but I did it anyway. And now I'm feeling sick. And I'm calling you. I'm like, oh dear. We were all young ones. I don't know in terms of doing it. Yeah. Okay. We have a fact sheet on microblading, and we have one on tattoos. They're not contraindicated, but I also had a patient who wanted to remove her tattoos. And it turns out that when they laser them, there are micropigments in your system, of course, not studied in pregnancy or breastfeeding. Maybe you might wait until you were done being pregnant or breastfeeding before you remove your tattoos. But okay, we could go on and on. We get asked about acupuncture and all sorts of stuff too, but that's a different talk. So let's talk about resources. And we are so lucky. Like I said, I did this long before I had these resources, and I am blessed to have them now. We get the prescription or the subscription for Hale, which, as I say, costs money. And we freely share that, by the way, with others that need it. And we use the online one because it's always up to date. I love LactMed. It just doesn't have every exposure, nor does it always tell you what the relative infant dose or the what Hale calls the Tmax, which is roughly when it's going to peak in the maternal serum. They also are often better about telling you what the absorption is if it's a topical product. So I use both. I rarely answer something on something I've never answered before in breastfeeding without looking at both. In terms of doing that. And I will say that the third place I go and look is the label, because the label's got redone in, I think it would be 2016. And they now are required to have something on breastfeeding to actually mention that breastfeeding is helpful to the mom and the baby, that you have to weigh that, you know, versus like if there's no data, you know, that you still need to be thinking breastfeeding is a good thing. And I think it's important for providers to know if the label says don't use it in breastfeeding, you might still choose to do it, but you would know that that's what the manufacturer is saying. Don't do it. You just have to be a little more careful. And you might wonder, like, why? Is it because there's no data, or is it because there's really a toxicity you should be careful about? Ashley, am I doing okay?
Yeah.
All right. Okay, so Hale, LactMed. LactMed's free. LactRx is LactMed in the app form. So both Hale is in an app form, and LactRx, for whatever reason, the National Library of Medicine wouldn't maintain the app for LactMed. They wouldn't keep it up to date. So Mother to Baby took it. So that's where you just have to go to the Mother to Baby webpage, but it's LactRx. It's updated just like LactMed is. I find, like I say, I look at both. When it's anything out of the ordinary or that I haven't answered recently, I find them both very, very helpful. Sometimes I look in Briggs, Drugs and Pregnancy and Lactation. They do have a section on breastfeeding, and Dr. Briggs died last year. Alicia Fornoff is a pharmacist down at SLU, and she's doing a lot of it now, and I think she's doing a nice job, and she's a little more interested in breastfeeding, so I see more on that. And let me say, Briggs for me comes up free under LexiDrug, which is, or LexiComp, which is part of my formulary at UNMC. So, you know, I always take advantage of those. Under my formulary, I also have access to Martindale's and Natural Products database, which, if I'm really lucky, will have something on pregnancy or breastfeeding, sometimes not. But we just get asked about so many things that are either somebody brought it back from another country and Martindale's is better for foreign medications, or it's part of that herbal whatever. So I'm always looking. And then ReproTox is my favorite database for pregnancy. It has medications, occupational hazards, you name it. It's very comprehensive. It has only a short section on lactation, but occasionally it's the one that if it's something really unusual, I'll only find it in ReproTox. So that's another one you have to pay for. It's about $400. So ask us for it when you need it. The pay ones, my grant pays for the databases. So take advantage of that in terms of doing it. I use Natural Products database all the time, half the time because I can't figure out what it is in terms of doing that. Okay, so, I just mentioned that, that the new pregnancy and lactation labeling rule. I was originally on this pregnancy and lactation labeling rule subcommittee for the FDA, and it was before my kids were born, let me think, or maybe when they were babies, like 1994 or something. This is how I realized that the FDA has their hands tied all the time. They brought us in, we said, the labels are terrible, you know, they're being misused, you know, this doesn't work. And it took like decades to get it changed, and it had to be changed by Congress. So even once they decided on what the change was, it took another 4 or 5 years for them, Congress, to get together long enough to vote on it. So it is shocking. They do their best. But it does now have a pretty decent lactation in some cases. So, you know, could be things are improving. There we go. This is what it comes up looking like this for me. And you can see, you know, wow, they actually had a decent something on breastfeeding. Be still my heart in terms of doing it. So, but it's mostly new drugs or whatever. The old drugs got grandfathered in. Okay, I keep mentioning Mother to Baby, but I believe strongly. We have about 300 fact sheets. I have written some of them. I've edited nearly all of them. We spent innumerable, oh my God, hours and hours on these. They're referenced. their pre-pregnancy, first, second, third trimester breastfeeding and maternal exposures. And they are on a lot of things, not everything. We keep writing more in terms of doing it, but we update them every 2 years or sooner if a major article comes out on them. So, do I think they're best for breastfeeding? Their main thing is pregnancy, but they'll have a paragraph, and certainly when I edit it, I make them change the breastfeeding. No, I update the breastfeeding part and try to make it more relevant. So, yeah, anyway, and there are things like hair coloring and nail products and stuff along with medications. Here's Hale, and as I mentioned, what's it good at? It is referenced, but Dr. Hale had a tendency sometimes, well, he told you about his own personal experiences with things. And as opposed to, I think Dr. Anderson more was using reference data. But I think Hale has improved on that. And certainly his young colleagues are more adamant about that now. So it's good. It's take this out to be Tamiflu. I had all these patients who didn't take Tamiflu when they had influenza because they were breastfeeding. And obviously the CDC says acceptable for use in breastfeeding. He uses that L1 to L5, which, you have to be careful with. It's obviously does not take into account the age of the baby or some other kinds of things. So, use with caution.
Is he the only one that uses that L1?
He made it up himself.
Okay.
Yeah. He also used to list the pregnancy codes, A, B, C, D, X. I actually sent him a note. I've met him a couple times and said, we've been trying to get rid of those for 25 years. And this isn't a pregnancy, resource anyway. You might consider not putting them in. Anyway, then he came up with this L1 through L5. I don't feel as strongly about it as I feel that ABCDX just was inaccurate and didn't work. This one, it is that they have, what's L3? Same thing as what was a C in the FDA codes. There are a million reasons you might be a C or an L3. The ones that are L4s and L5s you should take seriously. They're usually toxicity or they've seen problems, and it means that you would use them with extreme caution, if at all. So this is Anderson, LactMed, and again, it's hosted at the National Library of Medicine, and it's free, and it contains like an overview section, and then it takes you through is it in milk, impact on the baby, and impact on milk supply too. So it kind of takes you through the different things you need to be thinking about. They very seriously take the impact on the baby, which many studies don't tell you. They either tell you if it's in milk or if it has an impact on the baby, but not both. And Anderson tries to pull that together. So I always look at LactMed in terms of doing it. And then again, just a reminder that LactRx is free, but National Library of Medicine wouldn't host it, so it's now over on the Mother to Baby webpage. In terms of doing it, you can listen to a podcast about it if you want. We have lots and lots and lots of other podcasts that are in there, if that's the way you want to get your information. And so, yeah, Chris Stallman, who's a giant counselor in Arizona, interviewed Phil, and there you go. There's Reaper Talks, which I just mentioned, and again, is breastfeeding information, their strength. Well, they'd be the first. Tony Shalley, who runs this, is an obstetrician, and he'd be the first to tell you he knows something about it for sure, but it's not his strength. He does have somebody else, I think, writing the breastfeeding section. And it costs money. So, we'll provide it if you want it. Here's the information on mother to baby. There's a national phone number, but I tend to advertise that national phone number because the first question it asks when you call the 866 number is, do you need it in Spanish? And I sadly took German and French and Latin, and I do not speak Spanish. Bad person. And so we have 3 of the people that answer the phone that speak Spanish, thank God. They do our translations too. So all our fact sheets are available in English and Spanish now. And we actually have a whole web page frame that is in Spanish. We have a CDC grant to increase our utilization by people who speak Spanish predominantly rather than English. That's why, I mean, do not send someone to 559-5071 that speaks Spanish, because I will have to find an interpreter in terms of doing that. I answer that 866 number along with about 8 other people most days of the week. I also do the texting on Wednesday, some Thursdays and Fridays, and they can text chat. There's email and expert. I answer those on Thursdays. So you can always send it through to me, but the other people that are answering these are very well trained and know their information. So we are slowly transitioning over to advertising the joint numbers. Well, now we have joint numbers, joint email, joint other services. And so I think you can feel fine about that national phone number. That web page gets millions and millions and millions of hits, and it should get more because we are really careful about it being professional. The CDC and the FDA list us as their patient facing, as they should for information. They're our colleagues. Patient contacts you about taking Zoloft or sertraline while nursing. In general, you should do a happy dance when this is what they tell you, that this is the medication they're on. She's taking 50 milligrams a day in the morning, because you're going to ask, how much are you taking? So it isn't just the agent, it's when are they taking it and how much. It's just a short term, so working down through all the different questions that we would want to know, short term or long term. Will need it indefinitely. Reason for the prescription. I kind of gently ask this. Occasionally, it's if you're going to, think about alternatives, or even, start to think about are the benefits high in terms of doing it. It's nice to know why they're taking it. Depression. How old is the infant? 3 months old. You ask term. No medical issues. How often is the infant nursed, and are they supplemented, exclusively breastfed, multiple feedings a day? Does the medication affect milk supply? You're not asking the patient that, but you're thinking that. To anyone's knowledge, no. They don't have to answer anything if they don't want. Okay, so are we lucky? Has the agent been studied in breastfeeding? Yes. One of the first ones who actually knew something about, Kathy Wisner's a reproductive psychiatrist, did the data. They put like little movement things on babies' feet that were being breastfed this because they wanted to be sure they weren't sedated at all or whatever. I know, I'm trying to think of what she called those, but they were on the feet, and they didn't see anything. And I know she has never seen a baby show adverse effects from this. Relative infant death is pretty low. They've got serum levels though in some of the studies, and they're low. No side effects have been reported. It does have a long half-life of 26 hours. Peaks in serum 7 to 8 hours after you take it. So is that going to be one that you can time?
No.
Thank you. No. That's the problem with a lot of the psych drugs. They're really long, and they're long for a good reason. They work better. People, if you miss one, you're not the end of the world. But they're good. Fortunately, this is not a particularly hazardous agent, so you're okay with that. Is there a safer alternative? Not really. This would be a good choice. And also if she plans, people who've been pregnant once are often going to get pregnant again. It would be a good alternative in her, a good agent in her next pregnancy as well. Paxil has slightly less excretion of milk. So for some patients who got their tubes tied or are starting it, they aren't continuing it out of pregnancy. Say anxiety is more of an issue for them. Paxil is a little bit of a different kind of an agent. They might, but not very many people take paroxetine. Do the maternal benefits outweigh the risks? Almost always, in terms of doing it. in terms of doing that. So this is another one where I would explain caring for you means caring for your baby too. There are a bunch of studies on really depressed women and their infants, and the infants act depressed. It's interesting. Their growth and development is not the same with really depressed moms. And so there's good reasons times two.
I feel like we're seeing more of those studies too.
Yeah, they're trying, because I think, it's not something you can measure as easily or whatever. And I think we undertreat women's issues anyway. Do you know what I mean? There's like, well, if they just bucked up, they could be okay. And depression, and particularly postpartum depression, but I mean, depression of all those kinds can be really.
Well, I've seen moms that want to decrease the amount of drug they take during the pregnancy. And then they don't know really whether they should start it again now that they're delivered and nursing.
It's one of the, thank you for mentioning that. It's one of the risks of discontinuing these agents early in the pregnancy or midway through, is that they don't get restarted postpartum when people are really high risk for, this is true of our bipolar meds, because bipolar and postpartum can be really dangerous, and but also true of our antidepressants. So yeah, thanks for mentioning that. True enough. And then I'll just run you through codeine and the thought process. Is that okay?
Yeah. I think that's great.
So patient on 30 milligrams every 4 to 6. It's short term for vaginal lacerations, but as you know, that and episiotomies, all these kinds of things are not any fun. They're really painful for some patients. How old's the infant? 4-day-old, term, healthy. How often nursed? Exclusively breastfed, multiple feedings. Does the medication affect milk supply? Not to our knowledge. In terms of doing so, again, thinking through all of this. So the FDA warns nursing moms who take codeine to watch infants for sleepiness or other signs of overdose. That came after a woman was using codeine to treat cesarean section pain. And she was actually storing some milk, which is interesting, in a baby that young. But so she took the baby, she took the baby to the doctor on, if I get the days right, it was like day 5 or 6, and said, I have to wake my baby to feed. I have to like thump the feet and put a cold wash on, that kind of thing. And the doctor said, oh, everybody wishes their babies would sleep like that. Your baby's weight is fine. Don't worry about it. And so, she was taking this regularly because she had cesarean section pain. And on day 8, the baby never woke up. And so, the codeine converts to morphine. That's the actual effective part of it. The levels were very high in the baby. And high in her milk. And even though morphine doesn't cross terribly well to breast milk, it's the reason codeine has a black box. It was actually after that specific case that codeine carries a black box warning. Now, some women convert codeine to morphine more rapidly, et cetera. They did a study up in Canada where they actually looked at women who knew they were going to have a cesarean and did their pharmacokinetics and looked at who those people were, because this woman she was an immigrant. And as I recall, she was North African. But so it's not uncommon. You can see 16 to 28% of North Africans are rapid metabolizers for CYP2D6. So you could get the genotyping. It's just not going to work fast enough once the baby's already born, to be honest. I mean, you could, I guess. The FDA recommends doctors prescribe nursing women the lowest dose of codeine for the shortest period of time.
I remember when this change happened on the floor.
Oh, yeah.
And we started getting the alerts from pharmacy for T3 and
many babies don't have any problems with codeine, but I certainly have had people tell me that their babies were very sleepy from it.
I mean, Oxy if they're given Motrin, they're given Tylenol.
Yeah.
And Oxy if they need it.
Yes, right, which has changed, but like we used to.
Yeah. Everything was Tylenol 3s when I was there.
You are right. You are right. And so, Interesting, has it been studied? There's that relative infant dose, 8.1%. Genetically determined how much you convert to morphine. There's that half-life, peaks fast. Is there a safer alternative? Consider alternating. I just talked a patient through this, that, alternating with, take ibuprofen or acetaminophen every other, so you don't get that buildup in the baby in terms of doing it. And again, the patient I was talking to was Oxy, but had a fracture and they were going to have to do surgery to reset it. Well, you're not going to make someone suffer through that. That's how people end up quitting nursing or something in terms of doing that. So anyway, I'm kind of careful with any of these sedating, and the same story is if the woman is still feeling dopey or sedated, it's surely not the time to nurse, and they'll need to use, stored milk or something else in terms of doing it, or you have to watch the baby very carefully. That is a case up in Canada, was terrible, but so it can happen, and it's probably more likely in some of these people of color or whatever, pharmacogenetics kind of follows certain ethnic groups, so we're all different in terms of doing it. So just always remember you're dealing with the individual, both in terms of the mom and the baby and how they handle it. So always build in those safety measures. And I'm sure the pediatrician who reassured based on weight gain and whatever regrets, they see, you can see how it happens, but regrets.
So I guess I have patients who ask, so I'm postpartum 1 through 3 days. Is the oxy gonna bother the baby? I said, at this point in life, probably not, based on the amount of milk the baby's getting. But, we've got other factors besides epidural, spinal durumor,
I know you do.
all of those
Whatever
other
time.
things that may be making a baby sleepy.
I would be careful. They don't do a very good job of measuring how much gets into colostrum, to be very honest. And so you might end up with an increased concentration compared to what you think the relative infant dose is for well-established nursing. I would still watch the baby for sedation, and I would not nurse immediately after taking it. So this is I would not nurse just before taking it. So this is one of those ones where you're going to time your nursing. It's a great time to teach them, not to nurse immediately after taking it, but to try to wait a couple hours if they can. And you want to be realistic, and you want people up and around, you don't want them stuck in bed or doing whatever. So you're always weighing different things, but it is a great time to teach about timing nursing, watching the baby for side effects. Because I would still say, although I think it's a safer alternative in a way, it's a very potent drug. And you really wouldn't want a newborn with, half liver function or whatever it is to get very much of it.
Right.
I would just say, roughly what you say, but a little more. Of course, these poor patients.
I don't know how much they comprehend
Yeah.
in the early stages.
Most of the time, I think they want either all or nothing, and you aren't going to give them that. Sorry, that's not true. But I would say it's a good time to teach timing nursing, and a good time to teach always watch your baby for side effects. You don't want people to be anxious, nuts, for this.
Right.
But I think it's a great, you got a really powerful position.
So how about, I had a patient where I knew that the husband was going out to smoke marijuana in the car and then coming back in, and I could tell he was smoking. How much is that baby? I mean, okay, newborn, then he goes home with that parent in the house. How much is that baby getting of
Baby
that?
gets a little, secondhand smoke, for sure. Same thing for tobacco. The baby gets some, not nearly what you would if you were actually ingesting it or smoking it yourself as the woman that's nursing. Is that a wonderful situation? I mean, if he was out in the car drinking, it wouldn't be wonderful either.
Right.
In terms of doing that, because they're having a rough adjustment to parenthood, perhaps, I don't know. Postpartum nurses have a tough case in terms of that. I'd say the whole thing, which is don't smoke around your baby, no matter what it is, goes for the guy as well as the woman.
Yeah, that's kind of how I approached it.
Excellent. Well, see, you've been around the block several times and you're only gonna get so far. You don't want to have the baby not have a father or whatever. So you're always looking at the benefits and risks. But
Yeah.
I think people are not taking marijuana seriously enough. Now, I mean, like I say, I get people that argue, oh, they should be drinking instead of smoking or something. I mean, I don't know, but I mean, I think too much alcohol is a huge problem too.
Yeah.
So we, as humans, we must need things like that
Okay,
sometimes.
since I'm CBD that I see advertised at these,
Cannabidiol, yeah,
Yeah,
that's supposed to have a low level of THC. So, you notice, I believe that the current, thing we're gonna vote on November 6th about is to both allow medical marijuana, and I believe it has something about regulating it. So right now, because it's illegal and, we are not,
it's not regulated.
it's not regulated, it's illegal nationally and it's illegal in our state. So it's not well regulated. CBD, like I say, I think it might even be the Department of Agriculture.
Oh,
Might be the one regulated, don't hold me to that, just something like that. That it be less than 1% is what I think it is.
okay.
So, but the problem is it's not really very well regulated. Nobody thinks it's very well regulated. So is it likely lower risk? Probably. Could it have contaminants and lead, pesticides and stuff? Yeah.
Yeah.
You're supposed to have less THC in it, the euphoric.
Yeah,
I don't know. It's also a wild west out there. And like I said, I'm getting calls from some of these other states where it's legal and where it sounds like the potency is just incredible and dose counts, just like we've talked about dose and standard prescribed medications. Dose really matters. And they know very little about these high dose cultivars. So yeah, we are
interesting.
not, I mean, it's not that I don't know, it's that nobody knows in terms of doing that. It's interesting.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.